Good afternoon and welcome everyone to our online information support session. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. Today I'm joined by two staff from the Prostate Center at Cancer Care, Katrina Martin, clinical nurse specialist, and urologist Dr. Ardalan Ahmad. We also have a special guest from the Manitoba Prostate Cancer Support Group who will be here to share his story. So we're planning to have a frank discussion about prostate cancer and answer any questions that you may have. We're very pleased to offer this session with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Red River Métis. It's important for us to foster inclusion and reconciliation and encourage others to do the same. Before we continue, there are some basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you have a question at any point during the discussion, just click on the Q&A icon on your screen and type your question. You can also choose to send that question anonymously by checking the Send Anonymously box before you click the blue arrow to send. My coworker, Allie, is also here off screen, and she will be helping manage your questions as they come in. So it's my pleasure to first introduce Katrina Martin. Katrina is a clinical nurse specialist at the Manitoba Prostate Center. She has a master's degree in nursing and focused her thesis work on qualitative research methods and sexuality. She has clinical experience in sexual and reproductive health of young people and is currently seeing patients living with prostate cancer who require sexuality and treatment decision-making support. So welcome to all and welcome, Katrina. Some people may wonder why we decided to start this webinar talking about screening and symptoms of prostate cancer, but we thought that there might be some family members who were joining today that would be interested in this information. So why don't we begin by sending a poll to our screen? And in that poll, I'm just going to ask you to identify yourself if whether you're a patient or a family member. So I will do that right away here. I'm just going to find our poll. So you should be seeing a poll right now, and it's just asking you if you could identify, are you a person living with prostate cancer, a support person of someone living with prostate cancer, someone who's completed treatment, or someone interested in learning more about prostate cancer. So if you could just give us an idea, that would be great. So it looks like we have a good chunk of you that are able to complete the poll. And if you aren't able to complete the poll, if it's not coming up on your screen, you can always make a comment in the Q&A as well. But it looks like we have about 87% of you that have joined. So let's end that poll. And then I'm just going to share the results to our screen. So are you seeing that, Katrina?
Yeah, I can see that.
Yeah, did you want to comment at all on who's joined us today?
So about half of our participants is a person living with prostate cancer. 17% is a support person of someone living with prostate cancer. We have about a third of you guys as a person who has completed treatment for prostate cancer. And again, 17% is a person interested in learning more about prostate cancer.
Great. Okay, that's great. We have a good diversity of people that has joined us today. Thank you for that. Okay, so I'm just going to close that as well. So when we talk about prostate cancer, and we're looking again at maybe just some of the initial things that that people we're going to talk about screening as you know initially, but is prostate cancer, do you think, a more difficult cancer for men to talk about in general?
Okay, that's a good question. And I'm just gonna start off with a little bit of a background. I'm gonna just share my screen here. So can you guys see that?
Yes.
Okay, so just to give context, so the prostate is an organ. It's about the size of a walnut and it sits below the bladder and beside the rectum. So its job is to produce part of the semen, which is the fluid produced during ejaculation. So only male bodies, so bodies that are born with a penis, have a prostate. So to get back to your question of if it's hard to talk about prostate cancer, I think it's in society, men are not really encouraged to talk about their thoughts and feelings, especially with prostate cancer and how it affects the body in terms of the changes in one's ability to have an erection and control their bladder. It can make it very hard to talk about. Some patients are maybe embarrassed to talk about what their symptoms are with their healthcare providers, or they're just scared of what might happen next. So, a fear of the potential cancer diagnosis, the fear of treatments and side effects, and how some of the side effects might impact their relationships and partners. So, especially the side effects that impact our ability to have sex.
Yeah, well, that's understandable. And actually, I just realized today that it's kind of appropriate that we're talking about this because it's November, which we've
Hmm.
come to know as Movember, where people are encouraged to grow a mustache to, bring awareness to men's health issues, including prostate cancer, and trying to break down some of those barriers that exist for men to talk about their health. So it's good timing. Are there any symptoms that men should be aware of to help maybe detect prostate cancer early?
Most people actually don't know they have prostate cancer. It's very, very common for actually no symptoms, patients not to experience any symptoms. So, depending on the location of the cancer, some people may not feel anything, which is often the case. And again, depending on the location of the cancer, some people may experience changes in their urinating habits. So, this could be going to the bathroom more often, straining, not feeling like they're emptying their bladder, a weaker stream, uh, more trips to the bathroom at night, and not having control of the bladder. As you can see, most of these symptoms can also be associated with increasing age. So some people can easily dismiss these symptoms and not discuss them with their family provider.
Right. And that sometimes having an enlarged prostate as you get older, these are the symptoms that would result. And you go talk about
Hmm.
that later, I know. But so just recently, it came to my knowledge that doctors weren't doing rectal prostate exams, or some doctors had chosen not to. Can you tell us what's the basis for that change in screening?
Okay, so let's talk a little bit about what the digital rectal exam, so this is also known as DRE. So this is basically when your family provider physically assesses your prostate by inserting a finger through your rectum. So the rectum is the tube that gets rid of stool. So because the rectum is right beside, as you can see in this picture, beside your prostate, they can kind of feel for any lumps or bumps. So using DRE alone is not a good screening tool for prostate cancer because as you can see in this picture, you can really only feel one side of the prostate, and a lot of early stage prostate cancers can't be felt.
Mhm.
So there's a potential for cancer diagnoses to be missed if you're only using DRE.
Right. And so, what other way would a family physician screen for prostate cancer?
So the most common way is through a blood test called PSA. So this stands for prostate specific antigen. So this blood test measures the amount of protein that's made by the prostate and it's kind of circulated throughout your blood. So both cancer and non-cancerous prostate cells make this protein, and this is a better detection of potential prostate cancer compared to the DRE exam. However, the PSA not only this detects cancer, but it can also detect something called benign prostate hyperplasia, or also known as BPH. So this is where your prostate is big, but it's not necessarily cancerous.
Mhm.
Um, some providers may still choose to do the DRE exam in combination with the PSA blood test, because there's a small chance that the PSA can come back normal, but then the physical exam, your provider can feel some abnormalities. So another reason why the DRE exam is still being done actually is if your provider sees a change in PSA levels, and
Mhm.
often this is done also in our clinic. The PSA screening usually starts at around age 50, But if you have risk factors, so this is if you have a family history of prostate cancer or other cancers, or if you're Black or African descent, some people can start screening as early as even age 40. And just a comment, before you do a PSA blood test, you need to avoid ejaculating or any injury to that area. So some people say avoiding a long bike ride at least 48 hours before doing the blood test.
Okay. Interesting. So what is the PSA score? What would be a normal PSA score? How does somebody know whether they have elevated PSA levels? Does the doctor usually share that information when they start testing for this?
Yes, so this is like the normal PSA scores. So these are the normal levels. And as you can see, as you age, the what is considered normal looks a little bit different. And this is because when the prostate over time, as males age, normally gets bigger. So which is why the range of the normal PSA level also increases.
Hmm. Okay, and so we've heard about this term active surveillance. I'm not sure if that's still the term that's used, but what exactly does that mean?
So active surveillance. So long story short, so a urologist or radiation oncologist will discuss your stage of prostate cancer. So depending on where the cancer is, how much it's spread, and what the cells look like. So often you'll hear the term Gleason score. This determines the stage. So active surveillance is only for those patients with the lowest risk prostate cancers. So these are the cancers that have not spread and are still only in the prostate. And there's certain criteria um, that is discussed when determining where the stage is and whether or not the active surveillance is appropriate. So because prostate cancer is a slow growing, usually type of cancer, your doctor may advise active surveillance. So what happens during active surveillance is treatment is postponed and patients' PSA levels are monitored every 6 months. Um, they are doing your digital rectal exams once a year, and your prostate is biopsied every few years, and this depends on the results. So why are we doing this? So a lot of research has shown us that patients who are treated right away for these lower risk prostate cancers have very similar outcomes to patients who wait before getting treated. And this is offered because we understand that treatments impact the patient's life. So active surveillance prolongs the patient's quality of life. So in addition to that, when we look at research, it's also showing us that you can delay treatment for a period of time without decreasing the chances of curing prostate cancer, because the goal of active surveillance is still we eventually want to cure the cancer. Of
Mhm.
course, if there's any changes, so if the patient develops symptoms or the PSA level is rising, there's always a reassessment for need for treatment, and you can still choose treatment at any time.
So even if it's recommended that active surveillance recommended, if you wanted to begin treatment, you could still have that choice?
Yes, it's always a patient's, like it's their body, it's their choice. So,
Okay.
and we just want
Yeah.
to make sure they're making an informed decision, but
Yeah.
yeah, they can
Why
still
why
choose
would
treatment.
a patient typically want to defer treatment, even if it
I
was recommended?
I would not recommend deferring treatment if your medical professional determines that you need treatment. But some patients that I see may choose not to get treatment due to the fear of side effects of the treatment. So this usually impacts their sexuality functioning. So the inability to have an erection, this changes, there's a lot of changes that happen in body image and the fear of change in their relationship, if they have partner or partners, is some of the deciding factors. However, I've spoken to some wives or partners and they want the patients to be alive rather than being able to have sex.
Mhm.
Some of the treatments can also result in infertility. So, not being able to have kids, that could also be a reason. Um, some patients may want to try alternative treatments. And word of caution, alternative treatments may not be backed by research to be effective in curing the cancer. So, at the Manitoba Prostate Center, we are only offering treatments like the surgery and radiation that are proven to be effective in curing your cancer.
Okay. Thank you, Katrina. I know you're going to come back on later on after Dr. Ahmad's presentation to talk more about the side effects of possible side effects of treatment. So I'd like to invite Dr. Ahmad back to the screen and introduce him to our audience. Thank you. So Dr. Ardalan Ahmad is an assistant professor of urology at the University of Manitoba. He completed a Society of Urologic Oncology fellowship at the University of Toronto. Dr. Ahmad's research centers on outcomes in genitourinary malignancies. Clinically, his interests include urologic oncology and multidisciplinary oncology care, with a special focus on focal therapy for prostate cancer and advanced robotic surgical techniques. Sounds like a lot. Welcome, Dr. Ahmad. Thank you for making time in your schedule for us.
Thank you. I'm going to share my slides. Hopefully everybody can. Katrina went over the screening and diagnosis of prostate cancer very nicely. My talk today is basically going to be overview of how to diagnose and how to treat prostate cancer. Since I'm a surgeon, I'm mostly going to talk about surgery and don't really touch up on radiation therapy. So I don't have any disclosure related to this talk. My objectives are to talk about epidemiology of prostate cancer, how we screen for prostate cancer, what is the start age of screening, when to stop, what are the guidelines saying, what is the Canadian Task Force saying about screening for prostate cancer, how we diagnose with prostate cancer.
Okay, it looks like we might have just lost Dr. Ahmad's connection. So we'll just ask him to try and reconnect. And as we do that, we'll just give a moment. There he is. We just lost you for a second there, Dr. Ahmad.
Can you see my slides still or no?
No, your slides have
Okay,
gone. Yeah, we'll try again.
How about now?
Yeah, that's good.
Perfect. So just to go over the objectives, a little bit about epidemiology of prostate cancer, how we screen for prostate cancer, how we diagnose, and what are the risk groups and what are the treatment options, and a little bit about cancer survivorship, which is basically from the time of diagnosis till patient passes away from other causes. In other words, how to live with prostate cancer after diagnosis and treatment. So, as you all know, prostate cancer is quite common. In fact, it's the most common cancer of a solid organ in North America and Western Europe. 1 in 6 to 1 in 8 men are going to be diagnosed with the cancer in their lifetime, but fortunately, only about 2, maybe 3% of men will die of the disease. Overall, around the world, around 7% of men are diagnosed with prostate cancer, but importantly, in the next 25 to 30 years, we expect at least a 25% increase in incidence or new cases of prostate cancer being diagnosed. So it's generally a big health problem, and it's going to be, we're going to see more and more prostate cancer because our populations are aging and becoming older and older. So this is the anatomy of prostate. As you can see, the bladder is on top, prostate is in the middle, and then this is the muscle that helps men or women to control their urine, called urinary sphincter. Importantly, while the prostate is deep in the pelvis, there are very important organs close by. So back in the back is the rectum, and above is the bladder and the ureter. But importantly, in men, the nerves that help a man get erection and be able to have sexual activity run very close to the prostate. And that's one of the reasons that most of prostate cancer treatments are unfortunately associated with some functional or some functional outcomes that are not favorable, including sexual dysfunction and inability to control urine. For many years, the only screening method we had was to perform a prostate exam through the rectum called digital rectal examination. But in late 1980s, FDA approved prostate cancer for monitoring, and later on in early 1990s, PSA was approved for as a blood test for screening for prostate cancer. Obviously, everybody was excited about it. The use of the PSA helped us find more and more prostate cancer because a lot of patients were asymptomatic. And with the blood test, we kind of suspected that there is cancer, and on further investigation, we find the cancer. As you can see in the graph to the left, once we started using PSA more and more around early 1990s, the number of patients who were diagnosed with low risk or intermediate risk prostate cancer increases, while the number of patients diagnosed with high risk disease, which is known to be fatal, decreased significantly. Additionally, looking at the graph on the right-hand side of the picture shows that we now diagnose patients at an earlier age. So instead of finding prostate cancer in men who are in their 70s, we find men in their 60s with prostate cancer. And also we find most of these cancers are still limited to the prostate rather than starting invading to other organs or going into the bones or somewhere else, called metastasis. While this PSA screening was very exciting, but then over 2 decades, we've come to realize with the PSA screening, we're finding cancers that probably will not affect men and their longevity. Essentially, many men have prostate cancer in their 60s, 70s, and 80s, and they live with it rather than die from it, and they die from other causes. For that reason, there's a lot of argument of whether we should actually do prostate cancer screening or not. So the disadvantage of PSA screening is causes significant amount of stress to the patient and their family. Overdiagnosis and consequently overtreatment of prostate cancer is a big, big problem. And finally, with any treatment that we offer for prostate cancer, there are side effects that can potentially affect a man's quality of life. So should we do it or not? This was about a decade ago in 2012. The American Task Force and subsequently 2014, the Canadian Task Force actually advised against using.
We're having a little bit of technical problems with Dr. Ahmad's connection right now, but there's back on.
That's not good. Sorry about that.
That's okay.
Okay. Okay, that's better. So what happened was that once we stopped checking for prostate, there were not too many doctors who will order the test, and patients were kind of shut to emergency rooms or doctors with advanced disease, meaning that the cancer has already spread out and there was no cure for it. So for that reason, the American Task Force actually revised their recommendation in 2016, saying that the screening for prostate cancer should be a shared decision making between the patient and their doctor to talk about the risks and benefits of performing this test, and based on that, decide whether the patient is interested in having screening or not. And the screening should be limited to men in their 50s, exactly 55 to 69 years of age. And before or after that age bracket, screening should not be offered. That being said, as Katrina mentioned, if there are certain men at high risk of prostate cancer for whom we start screening a bit earlier. So if someone has a strong family of prostate cancer, if they're from African descent, or they are known to have certain genetic mutations, this.
Yeah, I apologize for the technical problems. We'll see if Dr. Ahmad can come back and reconnect with us. So we're looking forward to being able to continue this discussion about the impacts of treatment and side effects that for a lot of our guests that have finished treatment may still be struggling with some of those side effects of the treatment they've had. But again, take an opportunity to type your questions. Dr. Ahmad, do you mind enlarging your screen? That's great. Yeah, just so that we can see your full slide. Thank you. Perfect.
So as of today, at least the American Task Force suggests that we should screen patients and we should have a conversation with the patient about the risk and benefits of prostate cancer screening with PSA. And if you're in the age bracket of 55 to 69, it is suggested we should start talking about screening. However, if there are certain risk factors, such as being an African descent, family history of prostate cancer, or certain mutations, The screening period can start a bit earlier, in fact, about a decade earlier, age 40 or 45. This is a summary of the major guidelines on prostate cancer screening. The American, Canadian, European, and NCCN guidelines all state that prostate cancer screening should start about the age of 50. And based on the PSA, we can decide how often we should do the PSA check. So if the PSA is quite low, let's say less than 1, usually we can space out the screening intervals to about 2 to 3 years. But if it's over 2, especially over 3, it's suggested that continue doing the PSA screening once a year. But when to stop the screening, and why do we say that we should stop screening for prostate cancer at a certain point? As I mentioned earlier, prostate cancer mostly is a very slow-growing tumor. So if someone is expected to live less than 5 or 10 years because of their other general health problems, it's not suggested to screen for prostate cancer because it's very unlikely that they're going to pass away from prostate cancer. So with that being said, considering that average or age of a Canadian man is about 80, 83 years old, most guidelines suggest that around age 70, the screening should stop, unless there is a reason to continue with the screening, such as the strong family history, the gentleman is very, very healthy and they expect to live over 10 years. That was the screening talk. And then, so now, usually this is where the urologist gets involved, is someone who had either an abnormal rectal examination, the prostate felt quite hard, or enlarged with some nodules, or there is an elevated PSA. So the next thing would be to decide how to diagnose prostate cancer. So as many of you know, the most common way to diagnose prostate cancer is to do a biopsy through the rectum, called transrectal prostate biopsy, or through the perineum. The needle goes through the skin between the scrotum and penis. This is the old way that we used to diagnose prostate cancer. However, since 2015, MRI has found its way into the clinical practice for urologists and in care of patients with suspected prostate cancer. We know that about 70 to 80% of prostate cancer are actually visible on MRI. And when we use special sequence of MRI, we can see the cancer. And once we can see the cancer, we can target that area for sure to make sure we are not missing an important cancer that is not in the location that we should take the biopsy. So the graph in the right lower part of the screen shows the MRI findings. So this is the area that the radiologist tells us it's suspicious for cancer. They kind of mark it for us, and then we go in and take biopsies. As you can see to the right-hand corner, the machine can actually track where the biopsies are taken from. So normally we would take biopsies from areas that are here and here, and we would have missed this cancer up top. And that's one of the main reasons that regular prostate biopsy misses cancer. It's that we're just putting the needle where the cancer is not located. And with the use of MRI, that problem has resolved significantly. So when we do MRI followed by biopsy, we diagnose more cancers that need treatment and less cancers that don't need treatment. So once we diagnose prostate cancer, the next step is going to be how to risk stratify prostate cancer. So one of the common things that we talk about is prostate cancer come in different shades and different colors, and not everybody with prostate cancer needs treatment. But how do we decide that? That's based on the risk stratification. Factors that are basically contributing to risk stratification are: what is the number of PSA at the diagnosis? Is it less than 10, between 10 and 20, or over 20? Was the prostate feeling abnormal? And if it was abnormal, how abnormal was it? And finally, what the biopsy pathology shows, specifically Gleason score, which is how we score the prostate cancer, or more recently, we use another term called grade group for ease of understanding. So the grade group of prostate cancer can be 1 to 5. The lower the number, the less aggressive the cancer, and vice versa. So if somebody has 3, 4, 5, they are considered to have clinically significant and aggressive prostate cancer. In the past, Dr. D'Amico was the one who suggested the risk stratification, and we generally risk stratify patients to low, intermediate, and high risk based on the factors I told you before. In the recent past, we started using the NCCN risk stratification, a bit more sophisticated and a bit more detailed. So as you can see, the box in the green, we call it favorable prostate cancer. These are the cancer that are slow growers. They're like a turtle. They move very slowly. They don't really move fast to organs outside the prostate or metastasize. These are the ones we call favorable because the risk of progression is low. Then we have the box in the yellow. These are the ones that are kind of like a rabbit. If you give them time, they will skip and go outside the prostate. These are the ones that have a higher Gleason score, like 4+3 PSAs over 10, and they have certain other adverse features. And finally, we have the red box, which is high risk and very high risk prostate cancer. These are like a bird. As soon as you open the cage, they just fly out. So these are the ones that are known to spread very quickly. And these are the ones that we like to catch early so we can offer the treatment and hopefully basically change the course of disease and prevent death from prostate cancer. So who should we treat and what are the treatment options? So the decision to screen prostate cancer or screen for prostate cancer is difficult, but also the decision to offer treatment and what type of treatment is quite complex. There is an interaction between different factors, what patient preferences, what are the cancer risks, and what is the life expectancy. So if one of the factors we look at is age, how healthy a person is, how long we expect them to live. The second factor is what is the patient wants out of the treatment? Do they care about their functional outcomes, meaning erections and the control of urine? Are they having erections? Are they having good control of urine or not? And the third factor is what the disease, what type of disease they have. They have low risk, high risk, intermediate risk, and we also look at certain adverse pathologic features such as intraductal prostate cancer or cribriform prostate cancer. When we use these, when we have all the information, we can basically discuss what treatment options are available. So this is a diagram showing the paradigm of prostate cancer treatments. It can be active surveillance or watchful waiting, observation, definitive treatment such as radical prostatectomy or radiation therapy. Sometimes we suggest hormone therapy, which is basically a way to make a man castrate so we can control the prostate cancer. And more recently, there is a lot of talk about focal therapy, which I will highlight at the end of my talk. So what is active surveillance? Active surveillance, as it basically implies, is we are actively watching the cancer, and we wait for the cancer to come to a point that we think if left untreated, it can harm the patient. So it's all about timing of the treatment and delaying the treatment till the patient needs treatment for prostate cancer. And the idea is by that, first off, we won't allow the cancer to spread and become problematic. But more importantly, we can preserve one's quality of life, including erections and stress incontinence. So overall, many guidelines actually suggest active surveillance for favorable prostate cancer. These are patients with low risk and very low risk disease, and some patients with intermediate risk disease. The advantages of active surveillance is it avoids and delays definitive therapy and its side effects. It limits overtreatment of favorable prostate cancer. And most importantly, at least based on the data we have, up to a decade after diagnosis, patients actually live very good. 98 to 99% of the patients are still alive, and about 20 to 30% of patients require treatment. So this is the eligibility criteria for active surveillance. If you remember the first time I showed this table, these are the patients who have low risk or very low risk disease. It is pretty much across the board standard of care to offer them active surveillance and avoid any radical therapy such as radiation or surgery. Some of the patients in the intermediate risk group that have a little bit of tumor, it's not too big, it doesn't have any adverse features, are also considered good candidates for active surveillance. So just a brief eligibility criteria: the PSA less than 10 or 20. The prostate is not really abnormal. The score is at least 6, sometimes 7, and less than 3/4 are involved. Usually we suggest any of these treatments we talk till age of 75, and after age of 75 we kind of switch to what we call watchful waiting, which I'll discuss in a little bit. And the surveillance protocol is not standard, but what we follow in Manitoba is every 3 to 6 months we do blood tests. Once a year we do a rectal examination, and every 12 to 18 months, or up to 3 years, we repeat the biopsy. Now that we have access to MRI, we try to avoid biopsy if the MRI is negative and the PSA has been stable. So one of the things that you might hear is, let's do the MRI, and if MRI shows no cancer and the PSA is normal, we can skip biopsies, which is quite invasive procedure and not favored by many men.
Dr. Ahmad, can I just interrupt just for a couple questions as you're talking about that? Somebody asked about having a CT scan rather than an MRI. Is that a practice at all to have a CT scan of the prostate?
CT, unfortunately, is not a good test or imaging to diagnose prostate cancer. It is a part of our workup for someone who has high-risk disease to see if there is a spread of cancer. But for primary imaging of prostate cancer to see if somebody might have prostate cancer, it's not a good test.
Okay. And if somebody's requesting a PSA test, does the doctor have a right to deny you a test? Or if the patient asks for it, should they get the test, even though it's not practiced after the age of 75, for example?
I don't think doctors would deny, but usually there's a conversation behind this request. So at least in my practice, I talk and say, well, I'll let them know what's the reason behind it.
Mm-hmm.
Obviously, not every 75-year-old is the same. There are 75-year-olds that are really healthy, and there's family history of longevity. Parents died in their hundreds. And in that case, we can still go ahead, but it's an individualized conversation. And that's what I can tell.
Okay, thank you.
You're welcome. Okay, so we talk about surveillance, meaning that we wait for the cancer to get worse and then offer treatment. What are the triggers for treatment when somebody's on active surveillance? The main trigger is when the cancer is worse on pathology, meaning that it was a Gleason 6 and now it becomes Gleason 7, 8, 9, or 10, or there is more cancer than what we expected. Usually we use the volume as a trigger for treatment for patients who have Gleason 7 or grade group 2 disease, and their cancer on second or third biopsy, or even more, instead of being a small focus, is now a bigger focus, and that time we offer them treatment. Also, there are patients who get really anxious being on surveillance and watching a cancer in their body. It's about 2, maybe 3% of patients get really nervous and they ask us to treat them. And anxiety could be a trigger for treatment as well. So as I mentioned earlier, now the major guidelines essentially say that surveillance should be offered to any patient with favorable risk prostate cancer, especially low risk and very low risk prostate cancer, and any other treatment is considered overtreatment. And the reason for overtreatment is most of these patients would live with the cancer and die of some other reason, and the chances of cancer spreading is very, very low. This is an updated table of active surveillance cohorts. As you can see, there are many cohorts around the world, but the 2 famous ones that we always reference is one from University of Toronto and the other one from Hopkins. The University of Toronto has a very inclusive criteria, meaning that they actually allow a lot of patients to get on active surveillance. While in Hopkins cohort, it's very restrictive criteria. They are very specific about who they put on active surveillance. And as you can see, the follow-ups are now in the range of 7 to 9 years across the board. But what I want to highlight is this cancer-specific survival and overall survival. So at 10 years, about 0.1 to 2% of patients have died from prostate cancer while on surveillance. But most patients actually die of other reasons. So in Toronto, if you look at it, about 20% of the patients die of other reasons beside prostate cancer. In Hopkins, about 7% and 0.1% died of prostate cancer. So that is the main reason we suggest active surveillance. We know that most men especially older men, unfortunately pass away from other reasons rather than prostate cancer. So why put them through a major treatment with major side effects while we know this cancer is not going to harm them in the long term? This is the graph showing the trends and pickup of the active surveillance over the past decade or so. In the States, still a lot of patients even with low-risk disease undergo treatment. It's mainly because of the way the healthcare system is designed. But in Canada, as you can see across the board, if you're eligible to have eligible for active surveillance, there's a good chance you're going to be put on it. In fact, at the Prostate Center of Manitoba, we offer treatment to over 90% of our patients, and it's one of the highest pickup rates for active surveillance across the nation. With that being said, let's switch to watchful waiting. It is a treatment, believe it or not. We just wait for symptoms to happen. And this is usually an option for patients who are not expected to live long, most of the time less than 5 years. And the idea is any treatment we offer in this age group, even in hormone therapy, which is injections in the belly, has major side effects such as osteoporosis, bone fractures, dementia, heart attack, stroke. So if the patient is already have a lot of comorbidities, rather than offering them treatment, we kind of keep an eye on the general health. And if they become symptomatic from prostate cancer, then we offer them treatment. In fact, a lot of times urologists don't even bother checking PSA because you're just not making a decision based on the PSA value, but rather than symptoms. So if you hear watchful waiting, this is the concept. The concept is if somebody is old and they're not expected to live, they are very comorbid, we will just watch. And if they become symptomatic, we can always offer them hormone treatment. How about surgery? So the surgery to remove the prostate is called radical prostatectomy. It's a bit different compared to the surgery that we offer to patients who have big prostate and have issues with urination. Prostate had different zones. There's a peripheral zone, there's a central zone, there's a transition zone. Most prostate cancer are actually originating from peripheral zone, and that zone is where we can feel with our fingers when we do the rectal exam and try to palpate the prostate. On the other hand, the transition zone is the zone that kind of grows around the tube that we feed through, called urethra, and pushes on it and makes it tight. So as men get older, they have difficulty with urination. When we do simple prostatectomy, we just remove the transition zone or the part that is pushing on the urethra. But when we do radical prostatectomy, the whole prostate is removed and sent to pathology for examination. So this is a schematic of showing what the incisions are like. So open radical prostatectomy, which it's been traditionally the standard of care. It's been around for about 50 years now, and it has there's major improvements in technique in the past 2 to 3 decades. We make an incision in the lower part of the belly, between the belly button and the base of the penis, and through that incision, we remove the prostate and lymph nodes and sew back the bladder to the tube that we feed through, called urethra. With the robotic surgery, it's the use of telescopes with a machine called Da Vinci that holds the instruments in place. The robot actually doesn't operate. It's the surgeon sitting in a console that move the instruments. The advantages of robotic surgery is magnification. So there's a tenfold magnification. So it definitely, as a surgeon, we see better. But more importantly, we can get to spaces that we really cannot easily see and get to when open surgery. As you can see, there are multiple small incisions rather than a big one, and these multiple small incisions are actually known to be associated with less pain and faster recovery, which we will talk about in a little bit. So this is basically a schematic of showing how the surgery is done. On the left-hand side, you can see an open surgery. This is basically showing the prostate. and that's the muscle that helps us control our urine. The prostate is carved out, and then the bladder is sewed back to the urethra. On the right-hand side is showing a robotic machine. So during surgery, we kind of remove the prostate. I have shown the anatomy of the prostate in the past, but kind of the prostate sits between the bladder and the urethra. Urethra is the tube that we pee through. During the surgery, we kind of carve out the prostate and stop the blood flow to the prostate and remove it. And once the prostate is removed, we have this gap between the bladder and the urethra, which we sew using different types of sutures. Here you can see this blue line is basically trying to show the blood vessels and nerves that are going along the prostate. The blood vessel and nerve go hand in hand. And these are the ones that helps a man to get erections. So ideally, you would like to preserve them. So after surgery, a man can control his urine and also be able to have erections. So this is basically a picture showing the robotic platform. As you can see, the surgeon is sitting in one of these consoles. There's an assistant at bedside. The patient is lying here, and the machine comes over the patient. And there are instruments that go inside the body, and using those instruments, we find the prostate, carve it out, and then sew the bladder back to the urethra. So what are the differences, or what are the advantages of robotic surgery over open surgery? And when it comes to oncological outcomes, meaning do we leave cancer behind or not? To how many lymph nodes we remove during the surgery? And cancer-specific outcomes, how long people live after the surgery, and how many people die of the cancer after surgery. There is no difference between robotic and open surgery. In fact, they're very similar, and sometimes we joke around and say, well, robotic surgery is taking the prostate out with a Rolls Royce while you can easily drive a Toyota. So it's more expensive, but the outcomes as far as cancer control is concerned is the same. Same thing goes for functional outcomes. So there's no difference in the rates of recovery from stress incontinence or recovery of erectile function between open and radical surgery. And we have to realize that at the end of the day, a robot is a machine, and it's more important who does drive the machine than what the machine is. So we'll come back to this in a little while, and I'll talk about what are the risk factors for having stress incontinence or having bad erections. But as far as oncological outcomes and functional outcomes are concerned, there's no difference between open and robotic surgery. So why are we using it? Obviously, as I showed earlier, robotic surgery, smaller incision, less pain, less blood loss, frequently no need to have blood transfusion, faster recovery. So usually with open surgery, it takes about 6 weeks to fully recover, while with robotic surgery, it could be about 3 to 4 weeks. One of the things that is a bit different is what we call bladder neck contracture. If you remember from the slides I showed before, when we sew the bladder to the urethra, that area can scar down and become very narrow. With open surgery, the risk of that complication happening is about 5%, but with robotic surgery is less than 1%. So these are the advantages of robotic versus open surgery. As a surgeon, I also like the robot in a sense that it's more ergonomic for me, so I don't get neck pain or back pain because I'm sitting and operating. So a lot of surgeons like that aspect of it, but when it comes to talking about outcomes, they're very, very similar. So what are the long-term outcomes and what are the complications associated with surgery? I'm not sure if there are any questions at this point or not, but if there are not, I can go ahead.
Actually, Dr. Ahmad, there are about 3 questions, but what I'm thinking, just for the sake of letting this kind of flow, is maybe we'll keep those to the end of the webinar, if that's okay.
Fine.
Are you able to stick around until the end of the webinar?
For sure.
Sure. And yeah, because we have about 5 minutes right now remaining before we switch back to talk about side effects.
So with any surgery, there are like the risk of bleeding and infections. Like, don't go too much in detail about them, but the 2 long-term side effects of surgery is stress incontinence, meaning that when somebody have a cough, sneezes, laughs hard or tries to lift something heavy, they cannot control the urine. The second long-term side effects is erectile dysfunction. So with the stress urinary incontinence, importantly, after surgery, we send patient home with a catheter, and once the catheter comes out, most men are gonna start leaking a lot. However, we advise them to learn how to do Kegels exercises before the surgery, and once the catheter comes out, we ask them to restart, and over time, they recover their function. What are the factors that affect recovery from this stress incontinence? So younger age generally is a good, it's kind of a favorable factor. So usually men over the age of 70, they have a hard time regaining their control. If a man has problems with controlling their urine at baseline before surgery, more likely to have problems after surgery to regain the control. Obese men, especially central obesity, is actually a known risk factor for post-op urinary incontinence. Surgeon and his or her experience is one of the important factors to consider. And there are certain medical conditions that make someone more likely to not be able to have control of urine after surgery, such as patients who have chronic cough. So if somebody has asthma or COPD and they're constantly coughing, they're never going to be dry after their surgery. Or if they have neurologic disorders that affect their ability to control their sphincter, such as Parkinson's disease. The good news is that it may take some time for the function to recover, but most men recover fine and they're completely dry. However, about 5, maybe 10% of men have significant leakage and they require treatment. And I tried to highlight treatments. Usually we start with Kegels exercises. There are urethral slings that we can use. These are like sling bands that we put to control the urinary leakage. And the best treatment is obviously artificial urinary sphincter. However, it is a surgery that is done, and it's a quick surgery with rapid recovery, very excellent outcomes, but not everybody's interested in having another surgery. The next long-term outcome is stress urinary incontinence. After stress urinary incontinence, I'm sorry, it's erectile dysfunction. Usually it's because of the damage to the nerve and the blood vessels that are responsible for erections. It is quite common actually after radical surgery to have erectile dysfunction. In fact, about 50% of all comers have problem with erection, need treatment even after 2 years. Such as stress urinary incontinence immediately after surgery, within the first 3 to 6 months, across the board, most men don't have any erections. Same risk factors for poor erections. So age over 70, if they have poor function to begin with, it's surgeon's experience and other medical comorbidities such as diabetes and hypertension make the recovery harder. What are the treatments? Obviously, we always start with the pills, Viagra, Cialis, or Levitra. There is pellets that can be used called Muse, penile vacuum pump, intracavernosal injections, and penile implant. These are basically the options available. When we are in clinic, we talk about all these options, and depending on what the interest is and how motivated someone is, we will start treatment. Obviously, we start with the least invasive, which is the pills, and gradually go over till we come to this part that we suggest maybe the best option would be to have a penile implant. This is a graph showing that among the 3 treatments, so the red is essentially surgery, yellow is radiation, and green is, or blue is just watchful waiting or active surveillance. As you can see with surgery, initially there's a lot of people who have problems with their erections, almost 100%, but over time, after 2 years or so, half men recover and half men still have issues. With radiation, it's the other way around. Initially, everybody's doing fine, but over time, in the next 18 to 20 to 42 months or 24 months, patients start getting more and more problems with their erections. So at about 2 years, about 40% of men, even after radiation, have problems with their erection. Same thing goes with control of urine. So initially, it's quite high with the surgery, and then over time, it gets better and better. With radiation, the control of urine or the accidents happen when people don't make it to the washroom, and the frequency is a bit less than surgery. I know I'm short on time, but I'm going to go quickly wrap up on focal therapy. This is a new kid in the block, essentially in the past decade, because now we are using MRI. We can see the lesion. And the argument is we know where the cancer is, why treat the whole prostate and why all those side effects while we can effectively kill the cancer uh, without affecting the structures that are vital for functional outcome. So for this focal therapy to be an option, there are certain criteria that I'll basically talk about a little bit later. But essentially, a patient should be eligible to have an MRI. We should be able to see the cancer. We should confirm the presence of cancer in that area. And then we can talk about focal therapy as an option. Focal therapy is a good option for people with favorable and unfavorable intermediate risk prostate cancer. It's generally recommended that we should not use it for high-risk disease because of high risk of recurrence and failure. So again, most of the time we offer it to someone who's in their, at least have 10 years of life expectancy. It's better to have one single lesion than multiple, but you can also offer the treatment to people who have multiple lesions. As I said, the best candidate is a 3+4 or 4+3 disease rather than high risk disease. And we would prefer not to have a lesion close to the vital structures, such as the muscle that helps us control urine, urethra, or the nerve bundles that help with erections. These are basically showing how the treatments are done. We can just focus on one spot, multiple spots on different ways. The different sources to use for basically killing the cancer, it could be ultrasound, could be cryotherapy, meaning we freeze it. You can use electricity, laser, or radio frequency ablation, and even brachytherapy, which is a form of a radiation therapy. The goal of focal therapy still is to eradicate cancer while preserving functional status. So the trifecta is we treat the cancer, there's no erectile dysfunction, there's no incontinence. In fact, most people have a temporary loss of erections and a little bit of stress incontinence, but after 3 months, most of them are back to baseline. So that's one of the reasons that most men who are candidate for this treatment are actually interested in it. However, I have to highlight that focal therapy, first off, is not covered by any of the governmental, basically, health insurance. So currently, it's just offered through private practice. We don't have it in Manitoba, but so we're in the process of bringing it to Manitoba, hopefully in the next year or two. And that would be my presentation. Sorry, I went over.
Oh, that's fine. Thank you, Dr. Ahmad. If you are you able to stick around until the end and then we can leave the questions? Okay, that'd be great. Well, let's bring Katrina back on. I know, Katrina, you had prepared some information also about some of the side effects that Dr. Ahmad has talked about, so we can maybe just skip over some of that just in terms of not repeating. But we did want to talk a little bit about maybe some of the other side effects that men talk about or might struggle with following surgery from a radical prostatectomy.
Do you want me to go into the side effects?
Well, just yeah, maybe
Just
some
a
of them
summary. Okay.
yeah, or just some of them that maybe Dr. Ahmad hasn't already talked about.
Okay. I think for the most part, like he did cover, Dr. Ahmad covered the urinary incontinence.
Hmm.
So just not being able to control your bladder, the loss of erections. Once the prostate is removed, there is also a lack of ejaculation and the orgasm changes as well. You might also experience maybe orgasm with a little bit of urine leakage is also quite common. There is changes in penile size as well, maybe 1 to 2 centimeters. And over time, like Dr. Ahmad said, it may improve, but it can take up to even 2 years recovery time. And like again, it depends on your health. So what your urine and erectile function was before surgery kind of determines what your recovery looks like after.
Okay. And in terms of in terms of for incontinence and Dr. Ahmad was talking about how that's going to be affected following surgery in particular, but are there lifestyle changes that people can make that might help with that?
Right. So lifestyle changes, so you can stop smoking, weight loss, reducing alcohol, caffeine, and carbonated drinks intakes, which increases our trips to the bathroom. So just kind of drinking and in moderation, and drinking water in smaller amounts as well throughout the day instead of larger amounts. Other things for incontinence is bladder training. So this is requires the patient to keep track of their bathroom time. So you kind of find the shortest interval between your bathroom trips. So if it's 20 minutes, you kind of schedule yourself to go to the bathroom every 20 minutes, and then you slowly increase the time between bathroom trips. And then I just want to add the Kegel exercises and just expanding on that point. There's pelvic floor physiotherapy. So if you have insurance, some patients actually go and see this physiotherapist that they specialize in training the muscles so that patients can have better bladder control, and can help with erectile functioning too. So some patients will see them before the surgery and then follow up after surgery as well.
Okay. Can we talk a little bit more about the options that Dr. Ahmad mentioned for erectile dysfunction in terms of if you could go into those in a little bit more detail? Because I know that some people have talked about not having success with some of the medications, and Dr. Ahmad said that was kind of the first approach. Can you tell us a little bit about how you would try these different things that might be helpful?
Right. So besides the pelvic floor physio, there's also eating well, so a heart healthy diet, exercise. So anything that's good for the heart is good for the blood flow. Those are some pieces that might be helpful. The penile pump, so that's a vacuum device that increases blood flow to the penis. So it uses a ring to keep the blood in the penis to produce an erection. And it depends on the patient and the person. Some people don't like this. It's a lot of trial and error with a lot of these methods. Medication, so there's the pills, of course, and this is taken orally. One of the mistakes that patients make is they take this with a meal, and for the absorption to be better, you actually need to take the pills on an empty stomach. And a key thing is you need to be sexually aroused for this to work. It's not a magic pill that you get an erection after you take the pill. You need to be sexually aroused, and erection happens in about 30 minutes to an hour. The injection. So this is particularly useful because it basically bypasses the erectile nerves that are needed to have an erection, and the injection is directly into the penile tissue. So it's very localized, which is why it's about 80% effective for patients. And they're called, usually we prescribe Trimex. So the erections happen in about 5 to 20 minutes. You do not need to be sexually aroused. With both of these methods, though, they are not to be used every day. You have to wait 24 hours between using each of these methods, or method. And then lastly, the penile implant surgery. It is covered by Manitoba Health. So this procedure involves placing a device. So it's tube cylindrical-like inside the penis, and it can be inflated to achieve an erection and then deflated after sexual activity. Of course, this is a more invasive one. So yes, we usually try the other methods first, before trialing, before doing the surgery. There's also shockwave therapy. It's it's an experimental treatment, but it is offered here. Most of these, so the pills, the injections, the shockwave therapy are not covered by Manitoba Health. And again, you need to try methods multiple times and at different points in time during the recovery period before ruling it out, because we find that some patients actually have better outcomes with some of the medications over time. As you saw in Dr. Ahmad's presentation, there's that graph of erectile functioning. And so if you try a method like 2 months after surgery, it might not be working. But if you trial this method maybe 6 months after surgery, you might realize that there's a different reaction and a better reaction, in terms of that. So just be patient, and yeah, be patient.
Katrina, I know you had a video, short
Oh,
little
yes.
video. Would you be able to share that with us?
Yes, I will do that right away.
And this is, we're going to hear also from Don later on about his experience, but this is also a story about Paul and his experience with prostate cancer.
Okay, can you see it?
Yes, yeah.
Okay, let me just see if I can make it bigger. There we go.
My name's Paul Nash. I'm 64 years of age. Back in 2009, I was diagnosed with prostate cancer. I then went for laparoscopic surgery and had the prostate removed. I had the surgery on the Tuesday and they sent me out on the Friday. So I was recovering quite quickly. I was still a little bit sore, but I was okay. Obviously, I knew from the beginning, I knew that I was both incontinent and I did have some I have to say it's some erectile dysfunction. It wasn't completely. With your erectile dysfunction, the assumption is it's all or nothing, and in fact it wasn't. I was still getting a message to say that my brain and my penis were in some way connected. Because although your function goes, your desire doesn't. So it did lead me to want to find possible solutions for that. If I'm honest, it wasn't plain sailing. I tried the needles, I didn't find them successful, because there's a lot to do and a lot to think about. And then having done that, you've then got to wait for it to work. So I went back to the hospital because they'd recommended you try a vacuum pump. So I arranged an appointment, got that one fitted, and very simple. Put it on, you apply the vacuum then gives you erection. There's a proper band that you have on the machine that then slips over your penis, which then maintains the erection for 20-30 minutes. There are a number of solutions to whatever it is, incontinence or erectile dysfunction. And like in all these things, if one doesn't work, keep moving on. Keep trying it. And you never know, if you come back to one of those, you might find that works. Of course, the erectile dysfunction does make you think about who you are as a man, your manliness about it. But to be honest, it wasn't something, it didn't affect me very much. It was only a passing thought, because I'd felt very secure in my sexuality beforehand, and it had never happened to me before. And my wife was very supportive on that. But it wasn't my fault. There was no blame there. There was no issue there. There wasn't something I wasn't doing or was doing. It's staying positive throughout all of this, that even if, in my case, even though I still have erectile dysfunction, I have adapted my life in such a way, and that's the way to do it. You adapt. And then once you've adapted, you then make that adaptation as good as possible. I think one of the benefits in terms of the relationship with my wife is has made me more sensitive, and that isn't about sex or anything like that. It's actually about trying to value her more. I'm not saying I'm very good at it, but it has made me more aware that that's really important, and that you can't separate sex out from every other aspect of your life. It's all intertwined.
Oh, thank you, Katrina. In that video, you talked a little bit about the identity of feeling like a man, and many men might, struggle with the emotional impact of this type of treatment and the side effects. Can you tell us a little bit about how they might be able to cope with that?
Okay, so the emotional impact of having these side effects is there's a lot of loss of identity. So of feeling like a man. So men who hold a lot of strong beliefs about masculinity or aspire to maintain, the traditional male traits of being tough, not showing emotion, they're really at an increased risk of psychological distress as a consequence of, the side effects from the cancer treatments. And yeah, sex is an important part of life, and the difficulties in navigating, the way the body changes can lead to conditions such as anxiety and depression.
Mm. So we haven't talked too much about androgen deprivation therapy and hormone therapy. Could you tell us just a little bit about that?
So androgen deprivation therapy, ADT, or some people refer to it as hormone therapy. So it's a treatment for prostate cancer that can be used by itself or usually in combination with radiation therapy. So it's not a curative treatment. It simply works by reducing the amount of testosterone in your body. So the cancer cells need testosterone to grow. So if you remove their source of food, you're slowing down the growth of the prostate cancer. So because of a decrease in testosterone, though, there is often a loss of interest in sex, and erectile difficulty can occur.
And any changes to the physical body or emotional aspects of that treatment as well?
Yeah, so because there's a decrease in testosterone, there's a loss of muscle mass and physical strength, and hot flashes. So if you have a female partner, you will now understand what they go through. There can be a growth of breast tissue as well, and loss of bone density. So, which is why patients that are on this, they are given calcium and vitamin D supplements and we encourage them to do exercise, so particularly weight-bearing exercises or even walking. You might feel more tired if you're on ADT. There's some thinning of body and facial hair as well. And again, increased risk of diabetes and heart disease and blood clots as well.
Can we talk a little bit about, just to jump ahead, about radiation and side effects from that, and how often do people often like go through radiation if they have? There's a question from one of our patients about
Okay.
about the radiation therapy.
So radiation, depends on what your radiation oncologist um, has prescribed for you as for treatment, but there are ones where it's over 2 weeks and you go every other day for about 2 weeks. So that's 5 treatments. Or they can be as long as 30 to 40 days treatments and you're coming every single day into the clinic. Does that answer that question?
Mm-hmm.
Okay. Some of the side effects from radiation is fatigue is very, very common. So urinary issues as well. So again, a frequency while you're on treatment is very, very common. Burning when you pee, um, unable to control your bladder is also common. In terms of bowel, so there's a lot of frequency as well, going to the bathroom, loss of bowel control, blood in the stool, rectal pain and swelling. And this, again, usually goes away after the radiation has been completed. Um, some of the longer term things like urethral scarring can cause blood in urine as well, can happen even 10 years after radiation, I was told. And sexual side effects, so erectile difficulty. So you won't notice this right away as patients. You might notice a decline in the ability to achieve and maintain your erections over time. And some patients just attribute this to age-related changes as well.
Okay. Just so that we have enough time to hear from Dawn, and also I'd like to bring all of you back on for questions for a few minutes at the end. So maybe you could just tell us a little bit about where couples may be able to seek support for sexuality counseling when they're going through this process.
Okay, so I'm not a sexuality counselor, but I can provide support and education and connect you to resources if you are a patient at the Manitoba Prostate Center. Can I just share my contact
That'd be
information?
great.
Okay.
Yeah.
So yeah, this is where I'm located in Winnipeg. You can also ask your nurse or doctor for a referral to me. You do not need to say what it's for. You can just simply state you would like to see me because you have treatment decision-making questions or sexuality concerns. Without going into detail, our psychosocial oncology team under the Hope and Healing program also has counselors that can help you navigate the body changes or relationship changes that occur as a result of prostate cancer or any cancer. And those that are supporting their partners, they often feel isolated in this process and experience. So you can find support as well from the Patient and Family Resource Center, which is on the first floor of the Cancer Care Building in McDermott, and you can connect with support groups.
Okay, thank you, Katrina. Okay, so we're going to have you also stick around so that we can have some questions at the end. I'd like to bring back Dawn to our screen right now, if you can join us. And Dawn is from the Manitoba Prostate Cancer Support Group. And yeah, there you are. Thank you. Thank you, Dawn. We just have to unmute yourself there. To unmute your mic. There we go. You're good.
Yeah.
So we have just a few minutes because I do want to leave some time for questions. So could you tell us just kind of quickly how you came to be diagnosed with prostate cancer and what treatment you had?
Well, my family doctor firmly believed that middle-aged men should be examined every year, screened for prostate cancer. That includes a digital rectal exam and PSA screening. This started from about age 45 for me. And the PSA would go up a little bit each year, but it was never a concern until it was. In my early 60s, I received a call from my doctor, and he said, your PSA level's at 5.2. And you heard earlier that the average for someone in their 60s is up to 4.7. He was concerned about it, and he referred me to cancer care. I met with an oncologist, and I had a biopsy. 12 core samples were taken, 3 came back cancerous. I had no symptoms. I had No problem with my stream. I wasn't waking up in the middle of the night 2 or 3 times to go. My digital exams were unremarkable. So the only possible cue that there was any problem with me was the PSA. So I'm really happy that he insisted that I get a PSA screening done every year. As far as treatment, uh, after the biopsy, my Gleason score came back low after the first biopsy. It was always below 6. My doctor called it vestigial cancer. He said there's cancer there, but I'm not going to worry about it. We're going to go into active surveillance. We'll do a biopsy every 6 months, and hopefully we'll keep doing that for the foreseeable future, and nothing will happen. I noticed at the outset that 56% of the people on this call are men that have prostate cancer. So they'll know a little bit about biopsies. Just as an aside, it's not a painful procedure, but it's very uncomfortable and awkward. And whenever they take a core sample, you can hear that spring. It's a little noise that comes up. And some of the guys in our group call it the staple gun. I'm just saying, it's not. It's a very uncomfortable procedure. But as I say, my Gleason scores were low, and that changed. In one 6-month period between biopsies, it went from under 6 to 9. Now, that took us all by surprise. Cancer had become aggressive. My doctor said it had to be treated right away. I had a choice of either surgery or radiation. At the stage I was at, he didn't think radiation was really a recommended option. So I wanted to get the prostate out. Opted for a open radical. Robotic was not available at that time. I kind of wish that it was. After that, I had a CT scan to make sure this cancer hadn't spread. And the surgery was set for within 3 months of that high Gleason score. And I was pretty pleased with the timing on that. Pending surgery, I was sent to a physiotherapist who gave me lessons on strengthening the sphincter floor, doing Kegel exercises. That came in handy after. After surgery, unlike Paul in that video, I was not out golfing right after surgery. As a matter of fact, I was catheterized for 5 weeks. And I got to tell you, for me, that was the worst part of the whole process, being catheterized. So after surgery, my PSA score showed that cancer was undetectable. That was for about a year. And then the PSA level started to rise. And the lymph nodes that had been taken out did not have cancer. So my doctor felt that maybe a few of the cancer cells had left the prostate and were embedded in the soft tissue, the prostate seat. So about this time, my oncologist retired and he referred me to a radiology oncologist, cancer care. We continued to monitor the PSA level. When I got to 2.5, he suggested, look, let's do some radiation therapy. I had 37 sessions over about 7 weeks, 5 days a week. Within 1 year after radiation, the PSA level was 0.01, which is referred to as undetectable. And after 7 years, it's still been that way. I was discharged from cancer care and referred back to my GP, but told to continue to get, even though I'm in my 70s now, to continue to get PSA screening so I'd know if the cancer ever came back. There was one side effect, well, several side effects, but there's one that I didn't expect, which was radiation burns in my bladder. That has resulted in some bleeding, but it's not right now a major issue. It's impacted my life, obviously. The side effects from treatment, and we've heard already about what they can be. Urinary incontinence, I've had some. Luckily, I did a lot of those Kegel exercises. So it's not bad for me. I mean, as Paul said, you adapt and move on. If I exert myself or I cough or I sneeze, there can be some leaking. I have to watch what I drink, obviously, when I go out in public because alcohol tends to loosen it. When I'm out at events where I may be seen, because I do presentations and I have a lot of meetings, I wear a pad. I'd rather be safe than sorry. Again, the last thing you want is a dark patch to appear at your crotch when you're in a room full of people. So I also tend to wear dark pants when I'm at meetings. So like Paul said, you adapt and you move on. It's not a major lifestyle issue for me. It's huge for some. Some of the men in our group basically have to wear diapers. The amount of incontinence is so strong, and some of them have had artificial sphincters put in, and we heard about that. Erectile dysfunction, and that is very much a quality of life issue. My doctor talked about nerve sparing before the surgery. He said, we'll try to do that. You know, the bundle of nerves, as has been pointed out, on either side of the prostate. Well, the nerve sparing wasn't successful for me. And I tried to augment it with pills. It helps, but it doesn't help enough. There are some changes, but we're all adults here. It's not suitable for penetration. Still, it's not the end of the world. My wife was also in her mid-60s when this happened, and she's very understanding. She was happy that I was alive, to tell you the truth. And we can still be intimate, and I can still achieve orgasm. I just can't. I can't complete the whole act. Doctors told me about some things I could do. Injections. That was a non-starter for me. Injecting myself. The implants. I know one or two fellows that have had the implants, and they say they're pretty good. I didn't do that. My wife and I coped and moved on, and we have a very strong relationship, and I'm very, very thankful for that. Supports. I didn't really access any supports past pre-surgery. Just my doctor and my family, and none of the men in my family had prostate cancer, so I had no one to bounce things off. I didn't even tell my friends about the diagnosis. It somehow seemed private, and I was almost embarrassed about telling my friends that I had prostate cancer. And I realize now that was a mistake, a bad mistake, because I felt quite isolated and very nervous. But I didn't know about the supports that are out there, and be honest, there weren't as many at that time. But I'm lucky I have a supportive wife who was with me every step of the way. That's why at our meetings, our public meetings, we love to see women in the crowd, because it's so important. For a man going on this particular journey, the prostate cancer journey, if he can have a significant other, a partner with him, to encourage him, to keep him on task, it's absolutely well, it's not necessary, but it's so helpful. There are other things that eventually I turned to for support besides my wife. Most importantly, being the Manitoba Prostate Cancer Support Group. I didn't know about them until after my surgery. When I was about to start radiation, I found them by accident. I was going through the newspaper and I hit the public service announcements that are put in for free, and I saw this Manitoba Prostate Cancer Support Group. They were looking for volunteers. So I called them up, and that was a godsend. I'll get into the specifics in a second about all the things that we offer in that group. But for me, it was the reassurance and the experience. The public meetings, we always ask new people to share their experience, tell everyone where they're at in their prostate cancer journey. And surprisingly, most want to do it. They get up and they speak in front of a room full of people. And just because they want to know if anyone else has been there, anyone else has gone through what they're going through, anyone else out there has felt what they're feeling, and can offer any insight or assurance. And there always is. No matter what stage you're at, no matter what you feel, no matter what you've been through, there are always people in that room who have been there and done that. And it is it's such a relief. It's been very, very, very helpful. I want to talk a little bit, if I have time, about the Manitoba Prostate Cancer Support Group. We hold monthly public meetings every third Wednesday of each month, except December. It's at the Unitarian Church at 603 Wellington Crescent. They go from 7 till 9. Next meeting is November 20th. Admission's free. and there's lots of free parking. At our meetings, we have a speaker. Every meeting is usually a medical practitioner. And they speak about the newest research, the newest diagnostics, the treatments, and coping with side effects. And there's always a Q&A after. And if you have personal questions, you can usually approach the doctor at the end of the night. And they're almost always willing to stay and talk to you. But there are also specialists in related areas. Our next meeting, we're having a psychotherapist. He's going to talk about the benefits of using psychological strategies to help cope with cancer. We have personal information kits for newly diagnosed patients. We do presentations at various community groups. We have a monthly newsletter sent electronically to our list. It contains tons of relevant information about prostate cancer. And the most recent one just came out this week. And we have a website with really helpful information. And it will direct you to our public meetings, and it will show you the archives of all of our newsletters. It's a really handy website. Now, I don't have the kind of technology that the other presenters have, but I can show you a picture. That'll give you some information about our website. So anyone that wants to take that information down, please do, or you can contact us at it's where is it? www.manpros.org. We're very happy to help anyone, and we do it for free because it's important, and we feel very strongly about it. So
yeah,
that's my
thank you. Thank you, Don. And we have that information here in the Patient and Family Resource Center, and be very happy to share it with anybody if you didn't get those details. And I'm with you. I like that old style sharing information myself. Keep it simple. But yeah, we're here a phone call away too. So just let us know if you have any questions. I'm going to bring Dr. Ahmad and Katrina back on if I can. There are some questions here that I'm hoping that we can get to. There was a question, just generally speaking, about following people that were in active surveillance that died of other causes. And I just wanted to clarify, the question had been, did that person die of, or did they possibly die from questions that had developed from cancer treatment? But just to clarify, Dr. Ahmad, I think what you were saying is that the people that died that were on active surveillance had died from other illnesses not related to cancer. Is that right?
Exactly. So chances of cancer spread while on surveillance is about 1 to 3%. Chance of dying from prostate cancer on surveillance is usually less than 1%. And as I showed, about 8 to 10% of men at 10 years die of other reasons, such as heart attack or something different.
Yeah. There was a question about the focal therapy not yet being available or being available at a cost, and asking, is that related to a shortage of money or a shortage of trained staff that can deliver that type of treatment?
So mostly it's because we need how can I put it? So up to this point, there was no one in Manitoba who can offer it. I'm trying to bring it in, so hopefully soon. It is a costly device, so just purchasing the device is $500,000 US. So it's a lot of investment, and even though we bring it, then there will be issues with compensation. It's a lengthy procedure. It takes actually 4 to 6 hours to finish one procedure. So that's why most places that have it actually do it in private setting, and unfortunately it's costly.
Mm-hmm. And there was a question about, is radiation a cure for prostate cancer? I was really happy to hear from Don about how effective because that was a lot of radiation that you went through, but it seems like it did the trick. Could we maybe Dr. Ahmad again comment on that?
Yeah, so radiation and surgery are very similar in how well they control cancer. It's as I mentioned in my presentation, so we look at the patient as an individual before deciding which of these treatments are appropriate. In an ideal world, and that's major recommendation, is that the patient should see all doctors, like a urologist, a radiation oncologist, and even a medical oncologist before deciding what treatment they want to get. So they hear all the stories, what are the outcomes, what are the side effects, then make a decision. But in reality is that we don't have that opportunity all the time. So as a surgeon, I always talk about radiation and give a general overview of what radiation is and how it works, what are the potential side effects. In my practice, as I mentioned earlier, is surgery is not good for everybody. But if you're less than 60, 65, we suggest you should consider surgery for different reasons. And the two most important one is if you get surgery, it's always you have option of radiation as Don had, but the other way around is not necessarily true. In fact, 9 out of 10 urologists will say, sorry that radiation doesn't work, I'm not going to operate on you. And the reason is it's because side effects are huge. Risk of injuring the rectum, being totally incontinent up to 50% of the time, and essentially there will be no erection. So for that reason, it's better for younger men who are expected to live at least 15, 20, 30 years to consider surgery rather than radiation. But it's a very personal decision. Some would say, I don't want to have surgery. Some would say, I don't want to have radiation. So it's a talk that you will basically have with your physician or physicians, and then it's a totally personal decision.
Somebody had a question specifically about their Gleason score, and again, correct me if I'm wrong, but they're mentioning their score was 3. I don't know if it's at 7 and 1 at 8. They had radiation and Zoladex treatment in October. They were wondering whether they should have another examination done for their Gleason score. Does that question?
I'm guessing there was a 7 and an 8, and that's why they were offered treatment. Maybe I'm wrong, but
Yes, three scores, I guess, at 7 and then 1 score at 8. I imagine that's what it was.
So essentially, it looks like this was a cancer that is on the higher risk side. Obviously, I need to know the PSA as well, but let's say it's a high risk prostate cancer, and they got radiation plus hormone, or just
radiation and Zoladex.
Okay, so generally speaking, after the treatment is done, the best indicator that the treatment is responding or not is PSA. With surgery, the PSA goes down to 0 if there's no cancer immediately after surgery. With radiation, it takes time. So usually it gradually starts going down. Sometimes there is a bump in the PSA called PSA rebound, but it may take 6 to 8 months before the PSA actually goes down. Ideally, the PSA goes as low as possible, which is 0. But as long as PSA is going down and it's not bouncing back up persistently, that's a sign of cure. We do offer biopsies if the PSA starts going back up and we feel like the cancer in the prostate is not dead, to make sure that if you're offering a treatment to the prostate, at least we confirm that the cancer is actually in the prostate and not somewhere else.
Mm-hmm.
The short answer, just the PSA at this time, no need to repeat the biopsy.
Okay. There's this question, I think we may have touched on this in the discussion already, but just a question about new issues developing after cancer treatment because of the body being in a more weakened state from all these side effects. Is that something that we see, like in terms of other health issues, not just side effects of the treatment, but other health issues now cropping up after someone has gone through this intensive treatment? Because it sounds like it's pretty intense and a lot of side effects.
So that's a good question. Most of the problems or most of the issues that a man is going to be experiencing is related to the treatment itself, which we talked about. Obviously, with the surgery, we clearly know what's going to happen. With radiation, there are certain side effects such as blood in the urine, blood in the stool, urgency, not making it to the washroom in time. There is data showing that when somebody gets radiation, it is potentially increasing risk of other cancers, such as rectal cancer or bladder cancer. And then the hormone therapy, Katrina nicely briefed out on what are the side effects. Hormone therapy is actually pretty aggressive treatment because it has major side effects. So fatigue and hot flash is the most common one, but osteoporosis, dementia, heart attack, and stroke are common side effects of these treatments. That's why when I talked about watchful waiting, I said we will not offer them to older men because you can actually see in front of you somebody's changing so rapidly. So those are the ones that come to my mind.
Wow. Well, let's hope for one day there being treatments that don't have such intense side effects. That would be, we can hope for those advancements in treatment for sure. Thank you all for joining us today, and thank you to our viewers for your great questions. We invite you to complete our survey at the end of this webinar because we really appreciate your feedback. It helps us to develop and plan for new sessions in the future. And just a note too, if you haven't already registered, consider the Patient Family Conference on November 29th and 30th. There'll be a variety of information sessions that you can attend through that. So thank you all again, and thank you very much to our guests for making the time today. Really appreciate the discussion.
Thank you.
Take care for now.
Take
Bye-bye
care.
now.
Bye.